if patient has progressed on platinum doublet, who then receives docetaxel or ramucirumab, and they have not received immunotherapy, they're getting immunotherapy. But if a patient has already received immunotherapy, I'm probably not going to go back to immunotherapy again. Even if it's with a different drug, I would probably think about a clinical trial or more chemotherapy. I don't ever go back to the same drugs I've used before, with some exception. If a patient had a very nice response to immunotherapy for a long period of time, then went on docetaxel or ramucirumab, then progressed, maybe I would consider going back to the immunotherapy, considering they garnered such a large benefit from this. But for the most part, if I have a patient who started on a platinum doublet, who then got docetaxel or ramucirumab, didn't get an IO for one reason or another, then I would consider IO in the third line. I would say for most of my patients, they're going to get IO either front line or second line. Docetaxel would probably come with ramucirumab as a third line or second line after chemo IO. And in that, we just don't know what to do. I think we have to think hard about clinical trials and novel strategies and further chemotherapies that may or may not work for these patients. Immunotherapy does not work in driver mutation positive patients, specifically EGFR and ALK range. Every attempt must be made to do molecular interrogation on all of our adenocarcinoma patients and all of our never smoking squamous patients before we make a decision about immunotherapy. We need more information, and whether immunotherapy combined to chemotherapy will work in this patient population is unclear, but start with a TKI. Start with a targeted therapy if you have an identifiable target. And if you're going to then decide what to do next, it's generally not going to be single agent IO therapy.